All right, this is the one I was supposed to give before, but that's okay. So we know that periprosthetic fractures in general are an uncommon complication, but can be really challenging to treat. They're about 1 to 3% of all failed arthroplasties, evenly distributed between anatomic and reverse. We know intraoperatively these can occur from surgeon error or during revision arthroplasty, and postoperatively they're secondary to trauma. Risk factors include female sex, poor bone quality, implant loosening. We also know there's a high non-union rate, oftentimes with transverse fractures, that should probably be treated early with surgical intervention. Wright and Cofield described classification system based on fracture location. A types are at the tip of the stem and extend proximal. B types at the tip of the stem extend distal, and C types are well distal to the stem. Treatment's typically based on location and implant stability. If you have a loose implant, typically these need revision. Stable implant you can treat with non-operative treatment, RAF, or revision arthroplasty based on the location. So management in a nutshell, non-operative treatment with these injuries, it's basically if you have a displaced fracture, acceptable alignment, and a stable implant, it's how we treat a standard humeral shaft fracture. If they fit the alignment parameters that we have, it's reasonable to treat non-operatively. Operative treatment is for poorly aligned implants with poorly aligned fractures with stable implants, displaced fractures with a loose implant, or a non-union after non-op treatment. Making a decision between ORAF versus revision is based on implant stability. We know from several studies that greater than 2 millimeters of radiolucency in 3 or more zones on the humeral shaft or a shift in implant alignment is associated with a loose stem. Also, as I said in the last talk, if the implant isn't working well, that's also an indication to potentially revise it. In general, most Bs you need to pretty much exchange, but there are some that you can actually fix, and most Cs you can actually retain the stem and fix unless it's loose. Non-operative treatment's reasonable for displaced fractures with acceptable alignment and a stable implant. And these are the numbers that we're all familiar with for treating humeral shaft fractures, and exactly the same indications are for a fracture with a stem. Interestingly, these numbers are based upon a study over 50 years ago, and we still use these numbers today. If alignment is outside these parameters, deformity can be created, as you can see below. So does non-op treatment work in general? Yeah, it works actually pretty well. Type Bs are at more risk for non-union, but aligned type C fractures with a stable implant do actually fairly well. So for the type Bs, you should probably watch them closely within the first couple months and have a low threshold to consider surgery. This is a case of George's that he gave me. This is a type C fracture with a stable implant, acceptable alignment, treated non-operatively to healing. So operative treatment is for poorly aligned fractures, displaced fractures with a loose stem, or a non-union. In terms of surgical technique, the B-type fractures, so the ones at the tip of the stem, typically you need an extended delta pectoral approach, remove the implant, use a long stem that bypasses the fracture by at least 2 to 3 shaft diameters. If you're going to fix these and you can get a reduction, we use a long proximal humeral locking plate with proximal unicortical screws or cerclages and distal full-length screws. And if you are going to use cerclages, the lat insertion is really the safe zone neurologically to pass cerclages. Type Cs, you can use either an anterior or posterior approach, really depending on the fracture location. If it's a midshaft fracture, you can use an anterior approach. A more distal third, you use a posterior approach. And again, your plate construct is based upon the location. If you are going to go in back, you got to identify the nerve, as I showed you in the last video. And again, we use cerclages proximally and full-length screws distally. Typically, you want to use a large frag plate if you're going to fix it, and use 4 holes proximal and distal to the fracture site, and try to overlap the stem tip by at least 2 shaft diameters. So there are a lot of nerves at risk when you're doing this surgery, and the bottom line is it's every nerve. When you're going through the front, it's the radial, axillary, and musculocutaneous nerves at risk, and then you add the ulnar nerve when you actually go in the back. We all know the coracoid as the lighthouse of the proximal shoulder. I kind of think of the lat tendon insertion as the distal safe house of the shoulder. You can use the 2.5 rule with regards to the radial nerve. We know that the radial nerve is 2.5 centimeters medial to the insertion of the lower border of the latissimus tendon, and it also enters the groove 2.5 centimeters distal to the lower border of the latissimus. We also know the axillary nerve is just superior to the upper border of the latissimus, so the lat tendon is the optimal place to work around the humerus. More distally, you want to bluntly split the brachialis and avoid the branches of the musculocutaneous nerve proximally and the radial nerve distally. Here's a case, 72-year-old, 4 months status post the total shoulder that was done by someone locally and had a painful and stiff shoulder prior to the fall, but had, per the patient and the notes, a strong rotator cuff. We can see a B-type fracture with a slightly overstuffed head that may have led to a stiffness. And for me, because this was an implant that was not working appropriately, we revised the stem, long stem, bypassed it with a similar technique that I showed you, and then made the head more anatomic. Here's an 80-year-old, 3 years status post a well-functioning total shoulder. She fell, had a B-type or AB fracture, depending on your classification. And I revised again to a long stem because of limited bone proximally for fixation. We used a long stem, fracture stem, and we repaired the greater tuberosity just like we would with a proximal humerus fracture. Here's a midshaft type C fracture that I already showed you of George's that had a well-fixed stem. This is a midshaft fracture below a shorter stem, therefore you can go through the front, and this was fixed with a long proximal humeral locking plate and a supplemental plate for poor bone quality. And here's a 72-year-old diabetic that had a low energy fault with a pure type C fracture with a stable implant. And for me, even though the arthroplasty is not pretty, she had no problem. She wasn't complaining about this. So I was not going to go and stir a hornet's nest with this, and I just went and fixed it through a posterior approach, distal humeral locking plate, proximal cerclages, and distal screws. So if we look at outcomes, Mark looked at 36 patients, largest series in the literature, 97% healing with either revision or OIF, 40% complication rate, 20% revision rate. Complications include nerve injury, fracture, periprosthetic fracture after the operation, implant loosening, hardware failure. So these are basically every complication you can think of was in the paper. So these are daunting operations. He also found poor reliability with regards to the Cofield classification, specifically with regards to A and B type fractures. Kumar looked at 16 fractures, all healed, but they became stiff, a significant number that led to poor function. Campbell looked at 21 fractures. He found a higher complication rate if they did not bypass the fracture site by 2 to 3 shaft diameters. And finally, Groh looked at 15 fractures. 10 were surgically treated with long stem implants and cerclages. He used no bone grafts in this series, no struts, no supplemental plates. So to kind of consolidate this information from the literature that we have, healing rates seem high if treated appropriately. Patients may lose motion that may lead to a poor or unsatisfactory outcome. Complication rates are high, so you have to be wary of that when you're doing these. In a stable implant, you can fix these by bypassing the tip by 2 to 3 shaft diameters, potentially using a supplemental strut or plate for poor bone quality. And an unstable implant, typically use a long stem, cemented stem with cerclages, not necessarily needing a supplemental plate or strut. So non-op treatment's reasonable for Lyme fractures, just like any other humeral fracture that we treat as long as the implant is stable. You can fix these for displaced fractures with a stable stem, revision arthroplasty for a loose stem, poorly working arthroplasty, poor bone stock, or a non-union. You can fix them through the front for most A's or B's, fix them through the back for most C's unless you have a short stem that you can also fix through the front. Be aware that healing rates are high, but so are complication rates. So both your patient and the surgeon should have reasonable expectations treating these. Thank you.